Hello everyone, I'm going to talk to you today about the use of cultured osteoblast in avascular necrosis of the femoral head. In a post-COVID world, unfortunately, the incidence of avascular necrosis has dramatically increased. Unfortunately, the people who are suffering are not ideal candidates for total hip replacement, and approximately around 70% of them will require a total hip replacement within the 3 years. This is the current statistics. The way osteonecrosis has evolved, my understanding of osteonecrosis is this, that it is osteonecrosis and not avascular necrosis. So you don't really need to restore the blood supply. Second is that core decompression works as a palliative surgery. It's not a curative surgery. Finally, whenever you're looking at osteonecrosis, you need to stage as well as grade the osteonecrosis. And I will discuss why osteoblasts are the future. Like I said, this has been around for 20 years, where now the cause of osteonecrosis is thought to be because of apoptosis of cells. Second thing is, whenever you see a patient of osteonecrosis, and nowadays we are seeing more and more often, we need to look at two things. One is the stage of the disease. That is, in early stage, we can offer the patient a hip preservation option. And second is the grade of the disease. By application of AALCO grading, we know what is the pathogenicity of the disease. How likely is the patient going to need a total hip replacement if nothing is done for him? So as all of us are aware, this is a Fickett and Arlake staging system. And second is the grading system originally devised by Steinberg. So what makes a patient likely to get a THR? These are the head at risk signs. So if there is more than 30% involvement of the volume of the femoral head, the lateral and the central pillar are involved. Already there is a depression of the femoral articular cartilage, more than 240 degrees of curve ball angle, and articular cartilage involvement of more than 30 degrees. Now these are, most of these you can see on an MRI and you can make out which are the patients who require this kind of surgery. Again, a very humbling statistics that irrespective of what stage you are looking at, if you are looking at a stage 1 Fickett and Arlake, if the patient has these factors, then he is going to require a total hip replacement, irrespective of whatever you can do in the current literature. So these are the 3 generations of orthobiologics, and AALCO or cultured osteoblast, I feel, represents the 3rd generation, because we have a definite cell line and a definite number of cells and a definite number of way to deliver these cells inside the patient's femoral head. Here, this is a slide that I found by one of the patients sent me, and osteoblasts are the only bone forming cells in the body. So if you need bone formation, you need to inject osteoblasts there. You can see that osteoblasts, because of the spillover, have found heterotropic bone from the area of spillover. So they are very bone active cells. So what we do is, basically in the first stage, this bone marrow is harvested and it is sent to a lab where it is cultured and in a particular media, and after 3 to 4 weeks you get these cells. The surgeon's role is basically to do a core decompression and a curettage to prepare an ideal bed for implantation of these cells. The advantages, like I said, is we have a good gel-based delivery of system to deliver these cells and a certain number of osteoblastic cells. So what are the contraindications of this procedure? Obviously 3 and 4 AVN require a total hip replacement. Second is that if there is a change in sphericity of the head, those people who are taking cytotoxic drugs, severe sickling disease, and severely restricted preoperative range of motion, where the range of motion is not going to improve after this process. These are the few things that you need to pick up on the MRI, that is delaminated cartilage. This is not ideal case. Again, this is a post-COVID specialty where nearly the full femoral head is involved. Again, 100% femoral head involvement on MRI. I don't think these are ideal cases for this procedure. Lesions which are very close to the articular cartilage, where the mere fact of doing a core decompression and curettage is likely to cause a fracture. And medial avian. Now, medial avian obviously does not require treatment. I have been following this lady now for nearly 3.5 to 4 years. Lesion is the same. The patient doesn't have any symptoms. AVN associated with FAI. What will happen is that the FAI symptoms will never go away. So this is what you need to look at. Post-sickling AVN, where arthrofibrosis of the joint, which is common with these people, is not going to make for an ideal case. So what are the advantages of this procedure? I feel that this is the best hip preservation option available to us right now, especially for a young AVN. We do not burn the bridges for a future total hip replacement. And as I have done this procedure for more than a decade, I feel that even after 9 years, the Harris hip score of these patients is comparable to a very well done THR. And the patient can do all his natural activities. I have a few cases to share with you. This is around an 8-year post-op case. As you can see, everything is well maintained, good range of motion. This is a very interesting case. Very young lady came to me with AVN. She had bilaterally collapsed hips. So bilateral, more than 2 millimeter collapse. And she did not want a THR, and at that stage I did this surgery. I'll just show you what I've followed up. As you can see the changes which are happening in the head. Here you can see the new bone formation inside the CT. This is the last X-ray. Last she visited me recently, she did not want an X-ray, but this is her function. Again, result at 8 years. This is a 10-year post-operative result. You can see the well-maintained joint space and function. 4-year post-operative. And finally, this is a case where recently they started measuring the volume of the femoral head involvement. More than 50% involvement, anterior and lateral pillar involvement. By all possible literature currently, this patient should have collapsed. And here I have an X-ray at nearly 2 years or so, where it shows that the joint line is very well maintained. So I rest my case. As I say, hip preservation is a necessity in young and active osteonecrotic patients, and autologous cultured osteoblasts in a correctly chosen case will give a good long-term result. Thank you so much.